Hi everyone, Xavier here. So I'm in my favourite room, which has got all my Mackay tables and more importantly my OSI trauma, traction and POET table. So I thought I'd talk to you from here. So let's think about the cases. We're going to park the first case just up here, ankle fracture. Now listen, you can treat that in a number of ways. We're not focused on the fracture and its treatment, we're focused on the degree to which you out there thought that you knew the right answer. The reality is actually there's really very little data about the management of unstable ankle fractures. And I know that because I've managed to convince NIHR to give us multiple £1 million. And you've got to prove that the data doesn't exist, and they do double check your homework. And we got it through an ethics committee, and we got it through the Health Research Agency. So the idea that we really individually know how to treat the ankle fracture is probably not realistic. Of course, we have our perceptions, and we have our practice, but don't forget community equipoise, where there is reasonable debate in different trauma meetings, where different bosses treat them differently depending which day of the week it is. That's when we have community equipoise, and that's when we should be able to recruit into the trials with a happy heart. Okay, next case, hip fracture. So hip fractures, those tell us about pragmatic trials, and the reason is if we're going to decide between internal fixation and arthroplasty for minimally displaced fractures, we've got to agree what a minimally displaced intracapsular fracture is. And I'm telling you right now, I can't get 2 surgeons to agree, let alone a whole country to agree. The Garden classification, that was just based on AP radiographs. So the posterior tilt, which people think might be important, that's not even in the mix. Powell's classification and Garden both have really poor inter and intra-observer error. That means 2 people can't agree on the same x-ray, and if I ask one person on 2 different days, they'll give me 2 different answers. Given that, we can't use classifications. And so I say, you and I understand what we mean by minimally displaced fractures, and we have to come up by some working definition. And so for the Fruity study, which is just about to open, so keep your eyes open for it, it's going to be part of the big white package. For the Fruity trial, what we're looking for is fractures that can be seen on an x-ray, i.e. not the classic MRI only diagnosis, so you can see it on the x-ray, but you'd be happy to fix it in situ, so it doesn't require a reduction maneuver. And that's a very pragmatic, because it involves you, the clinician, making a clinical decision. And then when I report the study back to you, I say these are the fractures we had because you recruited them. And that's the pragmatic eligibility criteria. Thanks very much. Don't forget the Equator Network. We're going to put the link to the Equator Network. That's the reporting guidelines. Every single study of every different design has its own reporting guidance. Use it and you'll produce a much better paper with fewer revisions. It was great fun last Wednesday. Hope to be back soon. Cheers. Take it easy.